Welcome to AETCM, the Emergency Medicine Channel, EM Rapid 2022. This is Dr. Sabha, ER resident at AIMS Kochi. Now, in this video, we'll be talking about eclampsia. So let's begin. Yeah, so to begin with, before we get to the major topic of eclampsia, we will try and familiarize ourselves with a couple of terms. That's the difference between chronic hypertension, gestational hypertension, pre-eclampsia, and then move on to eclampsia. So the major difference between chronic hypertension and gestational hypertension is that in chronic hypertension, the systolic blood pressure should be more than 140 millimeter mercury and diastolic blood pressure should be more than 90 millimeter mercury. But the catch here is that this measurement, or rather the patient should be having 140/90 blood pressure prior to pregnancy, and it is like to be diagnosed before 20th week of gestation, and it should be persisting longer than 12 weeks after delivery. So the three things here are blood pressure should be more than 140/90 and it should be existing prior to pregnancy, and it's to be diagnosed before 20th week of pregnancy, and it should be persisting longer than 12 weeks after delivery. And what accounts to be or rather what is called as a severe chronic hypertension is that measurement of systolic blood pressure which is more than 160 millimeter mercury, and diastolic blood pressure should be more than 110 millimeter mercury. Now this is chronic hypertension. Now moving on to the gestational hypertension. This and in this category, it's the systolic blood pressure and diastolic blood pressure, that is 140/90 millimeter mercury of measurement, should be existing in a patient after pregnancy has been, or rather after 20th week of gestation, or in the immediate postpartum period, but without any proteinuria. So gestational hypertension is hypertension which is present only after the 20th week of pregnancy or in the immediate postpartum period, but it should be present without proteinuria. Now, women with chronic hypertension, they are at more risk for placental abruption, preeclampsia, low birth weight, cesarean deliveries, premature births, and fetal demise. So chronic hypertension is more fatal or has a higher risk of mortality than gestational hypertension. In order to treat hypertension in women who are pregnant, there are two safer treatment options. One is labetalol and the other is methyl dopa. Labetalol is a beta blocker and methyl dopa is a centrally acting alpha-2 agonist. Now, what's to be noted is that all antihypertensives cross the placenta. Labetalol is generally the first line or first is the drug of choice to treat chronic hypertension and pregnancy, and the starting dose is 100 milligram per oral twice a day, and the usual maintenance is 200 to 400 milligram per oral, again twice a day. Now methyl dopa, which is a centrally acting alpha-2 adrenergic agonist, it acts by converting into methyl norepinephrine centrally, which will reduce the total peripheral resistance and hence brings down the systolic or rather systemic blood pressure. And it is started at 250 milligram every 6 hours, which is given per orally and titrated to achieve a desired blood pressure. And the usual daily dose is around 500 milligram to 3 grams divided in 2 to 4 doses per day with a maximum of 3 grams per day. Long-acting nifedipine may be added if blood pressure is not controlled with either of those drugs, that is methyl dopa or labetalol. And nifedipine which is a calcium channel blocker. It is started at 30 milligram per oral once a day, and it can be increased up to 120 milligram per day slowly if it is required to reach the desired blood pressure. Now, for acute management, hydralazine can be given in the dosage of 5 milligram IV or IM, or labetalol, which is generally the first line of drug that is used, can also be administered at a dose of 20 milligram IV, or a calcium channel blocker, which is longer acting like nifedipine, given at a dosage of 10 to 13 milligram per oral, can be used during pregnancy. Now, ACE inhibitors and ARBs are the two classes of drugs that are contraindicated because of the teratogenic effects on fetal scalp, lungs, and kidneys. Now, moving on, once we've understood what chronic hypertension and gestational hypertension terms mean, we will move on to the next major terms, that is preeclampsia and eclampsia. Now, what we need to know is that eclampsia is a complication of a pre-existing preeclampsia. Now, preeclampsia or gestational hypertension and preeclampsia is a complication of gestational hypertension. So basically, if a pregnant female has been diagnosed with gestational hypertension and also lands up with proteinuria, we now label this patient to have preeclampsia, and it's characterized by hypertension that has been diagnosed before 20 weeks of gestation with either new onset of proteinuria, or that is sudden increase in proteinuria, or development of HELP syndrome, which is nothing but hemolysis uh, HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelet count. So that's preeclampsia. Now, if preeclampsia gets into complication, then the patient will end up in eclampsia, which is nothing but preeclampsia with seizures. So basically, it is convulsive preeclampsia. So it's the development of new onset seizures superimposed upon preeclampsia in a woman between 20 weeks of gestation and 4 weeks of postpartum. Now, eclampsia, like I mentioned, is the occurrence of new onset of generalized tonic-clonic seizures or coma in a patient with preeclampsia or gestational hypertension. It's just a convulsive manifestation of preeclampsia. So, to sum up whatever we have learned so far, chronic hypertension is a term used for a patient with systolic diastolic blood pressure to be more than 140/90 prior to pregnancy or before 20th week of gestation and lasts longer than 12 weeks postpartum. Gestational hypertension is diagnosed after 20th week of pregnancy, and it can lead to preeclampsia and eclampsia. Now, gestational hypertension with the new onset of proteinuria after 20 weeks of gestation or increase in the proteinuria or development of HELP syndrome will push the patient to have preeclampsia. And if that goes offhand, or gets more complicated, or has a convulsive manifestation, then it lead to eclampsia. Now, diagnostic criteria for preeclampsia includes two things. One is mild preeclampsia, and then there's a criteria for severe preeclampsia. Now, mild preeclampsia is systolic blood pressure of 140, more than 140 millimeter mercury, or diastolic blood pressure to be more than 90 millimeter mercury, and proteinuria to have a proteinuria more than 0.3 gram in a 24-hour collection, and the patient should be more than 20 weeks of gestation, and there should be no other systemic signs or symptoms. And this will categorize preeclampsia as into a mild category. Now, severe preeclampsia consists of blood pressure which is more than 160/110, and it's to be measured on two different occasions, at least 6 hours apart, with the patient being at rest. And it shouldn't be complicated with other systemic and it will be complicated with other systemic signs and symptoms such as visual disturbances. Patient will complain of blurring of vision or of transient blindness, scotomas, or mental status disturbances, or the patient will have other systemic manifestations such as pulmonary edema or cyanosis, or epigastric or right upper quadrant pain leading to abnormal liver functions. Basically, like developing HELP syndrome, thrombocytopenia, low platelet counts, oliguria with urine output being less than 500 ml in 24 hours, or if the patient has a proteinuria of more than 5 grams in a 24-hour collection, or more than 3 plus on 2 random urine samples, which is collected at least 4 hours apart, and also fetal growth has been affected and it has led to retardation. The risk factors are first time uh, patients who are getting pregnant for the first time, or multiple pregnancies, or women who are obese or who have conceived at a later age of more than 35 years, or if they have multiple comorbidities such as diabetes, hypertension, and CKD, are more at risk of developing preeclampsia and eclampsia. Now, when we come to the major, we're moving on to the major topic, that is eclampsia. Like I said, it's a convulsive manifestation of preeclampsia or gestational hypertension, and it is to be suspected and treated in any pregnant woman who has crossed more than 20 weeks of gestation and or in a range of more than 20 weeks to less than 4 weeks of postpartum, who develops seizures, coma, or encephalopathy. And it can present with seizures in a patient with normal or with normal blood pressure also. So it's not mandatory that the patient should have elevated blood pressure or proteinuria. So basically, if a patient who's not known to have any seizure disorder uh, ends up with seizures or convulsions during pregnancy after 20 weeks or before 4 weeks of postpartum, eclampsia has to be suspected in such patients. And management majorly includes treatment of seizures and prevention of recurrent seizures, prevention of maternal hypoxia, prompt delivery, and most importantly, bringing down the blood pressure which has been elevated. And but the definite treatment of eclampsia remains prompt delivery. So we have to facilitate urgent delivery of the fetus, and we treat the seizures with magnesium sulfate, which is given as loading dose of 4 to 6 grams IV in 100 ml aliquot given over 20 to 30 minutes, followed by an infusion of 2 grams per hour for at least 24 hours. Moving on to the laboratory investigations, here are some of the laboratory investigations which are done majorly when we're suspecting preeclampsia. CBC differential count will show us hemoconcentration, that is falsely elevated hemoglobin levels with fallen hematocrit value, and low platelet counts will point towards severe disease. Similarly, deranged LFTs and RFTs will point towards severe disease. And LDH levels will be elevated in the body because of ongoing microangiopathic hemolysis. Basically, with hemolysis, there will be rise in the LDH levels. And proteinuria will also be seen with 3 plus proteinuria will indicate a severe disease along with more than 5 grams in a 24-hour collection again suggests severe disease. And protein to creatinine ratio of 0.1 to 0.3 uh, over a span of 24-hour collection would also be noted in a patient where we're suspecting preeclampsia. And uric acid levels, which are more than 5.5 milligram per deciliter, will indicate preeclampsia, which is superimposed on chronic hypertension. So let's just say a patient like this has approached you in your ER. The management is not very different from how we deal other emergencies. It's always the ABCD approach. In that is airway, all we do is see if the airway is patent and also if the patient is able to maintain this patent airway. Breathing wise, we check for air entry being bilaterally equal, whether the chest excursions are good enough, is the patient being oxygenated and ventilated enough, whether the saturation has been maintained, how's the respiratory rate, the pattern, and then we move on to the circulation aspect of it, where we check the patient's heart rate and blood pressure and see if the patient is bleeding. So basically, the approach doesn't change at all. It is airway, breathing, and circulation. And wherever we find faults in any of these uh, entities, the parameters, we fix it. So if at all a patient is having an ongoing seizures, we see if the airway is patent or if the patient's, and how well is the patient being able to maintain this patent airway. And we provide the patient with high flow supplemental oxygen in order to prevent maternal hypoxia. And again, if the ventilation is inadequate, then we move on to the uh, then we move on to fix it. That is, we intubate the patient, and if the patient has seizures or if we want to like prevent recurrent seizures, the treatment of choice remains magnesium sulfate, which is, like I mentioned, given in the loading doses of 4 to 6 grams IV, which is given over a span of 5 to 10 minutes. And it is followed by a maintenance dose of 1 gram per hour for 24 hours. And a further bolus dose of 2 grams can be given if the seizure recurs. Now, there's an alternative regimen for this, wherein we give 5 grams of magnesium sulfate on each of the buttocks, so totaling up to 10 grams. So that's an IM approach, but the main, or rather the most popular treatment would remain an IV administration of magnesium sulfate, which is given in the loading dose of 4 grams, and then we maintain it with an infusion of 1 gram per hour for 24 hours. Now, how do we deal with it when we talk about the key principles? Is that if the seizure is witnessed, we maintain the airway patency and we prevent aspiration. Because of note is that the pregnant females are considered to be full abdomen patients, and then and they're nearing their they're towards the end of their gestation or pregnancy term, so the chances of aspiration will be high. So our priority is to maintain the airway and to prevent aspiration, and if the ventilation is inadequate, to intubate the patient. And we roll the patient to her left side. Again, another measure that we take in order to prevent aspiration if the patient is actively seizing. And we prevent maternal hypoxia and trauma that the patient is seizing by providing high flow supplemental oxygenation um, oxygen, and we treat severe hypertension and recurrent seizures. And the mainstay of eclampsia remains to promptly deliver the fetus. So just to freshen up, the treatment of uh, pregnant female with eclampsia in order to treat and prevent seizures is magnesium sulfate, which is given in the loading doses of 4 to 6 grams IV with the maintenance dose of 1 gram per hour for 24 hours. Now, magnesium sulfate is renally excreted. So the patients who have renal insufficiency, in such patients, the dose of magnesium sulfate, which is initially given, is reduced from 4 to 6 grams to 2 grams IV bolus, that is given over a period of 5 to 10 grams, and we obtain serum magnesium level before we increase the subsequent doses. Because the major side effects of magnesium sulfate are two things. One, it causes hyperreflexia, and second, it causes respiratory depression. Now, there are other side effects too, like flushing, diaphoresis, hypothermia, hypotension, and flaccid paralysis, but major things are hyperreflexia, and most importantly, it causes respiratory depression. So, when we take in serum magnesium levels before we increase the subsequent doses, we will know if we are reaching the toxicity or toxic levels of magnesium sulfate, and clinically we can suspect magnesium toxicity, that is with patellar reflexes being diminished and respiratory rate slows down. And we replace coagulation factors if there's coagulopathy, or if the patient has ended up with DIC, low platelet counts, and patient is, has developed bleeding manifestations. We see the cause, we treat the cause, and we obtain emergency obstetric consultation for prompt delivery, which yet remains the mainstay. The definite treatment of eclampsia is prompt delivery of the baby. And if obstetric services are not available, then we stabilize the patient as best as possible. We prevent maternal hypoxia. We maintain the airway patency and adequate oxygenation and ventilation, and then we transfer to a center wherein obstetric services are available, because no matter how no matter how you treat eclampsia, but the mainstay remains prompt delivery. Mainstay remains prompt delivery of the baby. Now here is a tabular column of that comprises of all antihypertensives which can be used in order to bring down blood pressure of a pregnant female with hypertension. One is labetalol, which is the first line agent, a selective alpha and a non-selective beta agonist. Its onset of action is within 5 minutes. Hydralazine is another drug which can be used, and it's an arterial vasodilator, and an onset of action is within 20 minutes. And nifedipine is the third option which can be used, which is a calcium channel blocker with onset of action being within 10 to 20 minutes, but it is not FDA approved to treat hypertension. Now, labetalol is given in a loading doses of 20 milligram IV, then 40 to 80 milligram IV can be repeated every 10 minutes until desired blood pressure is reached with a maximum dose of 300 milligram, or we can start an IV infusion at the rate of 1 to 2 milligram per minute, and we can titrate it as per the blood pressure. The advantage is that we don't see reflex tachycardia and profound hypertension as we see in hydralazine, but higher doses can cause neonatal hypoglycemia, and longer usage has been associated with fetal growth retardation. And hydralazine, which is like I mentioned, an arterial vasodilator. This is given in the doses of 5 milligram IV or 10 milligram IM, and you can repeat it at 20-minute intervals. So that remains a drawback because you have to wait till 20 minutes before the next dose can be given, and maximum you can give up to 20 milligram. Now, nifedipine, which is a calcium channel blocker, it's given in the dosage of 10 milligram per oral, and we repeat in 30 minutes if necessary. But like I mentioned earlier, it is not FDA approved to treat uh, hypertension. So this is eclampsia, basically a convulsive manifestation of gestational hypertension or pre-eclampsia, wherein a patient will have a new onset of generalized tonic-clonic seizures or coma. And lab investigation wise, we'll see hemoconcentration, fall in hematocrit value. There will be proteinuria, as we see in pre-eclampsia. Then there will be platelet drop and derangement of LFTs and RFTs, pointing towards a more severe disease. And then when we move on to the treatment aspect in the ED, it is like we treat any other emergencies, the same old ABC approach, wherein we look for the patency and also the maintenance of patent airway. We not just um, stop or terminate the ongoing seizures, but we also prevent subsequent episodes of seizures with magnesium sulfate, which is given in the loading doses of 4 to 6 grams IV, with followed by a maintenance dose of 1 gram per hour over 24 hours. An alternate IM regimen comprises of 5 grams, which is given on each buttock to a maximum of 10 grams. And subsequently, doses of 2 grams can be given as bolus, that is over 5 to 10 minutes, in order if seizure recurs. So this is how seizure aspect is tackled. Ventilation is tackled with high supplement oxygen, and if it is still inadequate, we go ahead and intubate the pregnant female, and we prevent aspiration. We roll the patient to the left side if the patient is actively seizing, and we treat hypertension with the following drugs, as I mentioned, labetalol being the first line, hydralazine and nifedipine are the two other alternative options that can also be used. And like I have mentioned multiple times in the past too, the mainstay is prompt delivery. So we give an obstetric consultation for prompt delivery of the child, and if it's not, if those services are not available, then we stabilize the patient and refer the patient as early as possible to a facility wherein obstetric services are available. So this is eclampsia in a nutshell. Thank you.